So I'd like to welcome everybody to the third Refugee Nurses of Australia Forum for 2020. I'm Sandy Eager, the current chairperson, and I'd like to start proceedings today by acknowledging the Indigenous people of where I am presenting to you today. That's in Liverpool and Sydney, and that is the Tharawal Gadigal people of the Eora Nation, and I'd like to pay my respects to their elders past, present and emerging. Today, as I said, this is our third online forum, and today we have two fantastic presentations brought to us from different parts of Australia. And so today we've got Heather Roberts, and Heather is the clinical nurse consultant for vulnerable communities in the Darling Downs Health District region in Queensland, and Chedza Malunga, who's the team leader at the Monash Refugee Health and Wellbeing in Victoria, and her two colleagues who'll be presenting today on her behalf, Nahad and Becca. So as in the format in previous things, we'll get the presentations going. If you do have questions for our speakers, please can you use the Q&A function at the bottom of your screen, and then at the end of the session I'll come back and host those questions back to our presenters. So we'll start off today with Heather, and Heather will do her presentation first. So take it away. Thank you, Heather.
Thank you, Sandy, and appreciation for the opportunity to speak. And it would have been nice to be in Melbourne, I must admit.
Yes, indeed. Looking forward to the shopping. Sorry.
Yes. Look, I would also like to extend the land that we meet on here in Toowoomba, and that's the Djarawar and Guybil people. So, and you will all have your people of your lands where you are. So I'm going to share my screen. Hopefully it all goes well. And bear with me, I'm just trying to... Can you see the screen? Thumbs up? Good, okay. Look, thank you all very much for the opportunity. This was, well, I'm talking about the Nurse Navigator for Refugee Health project, which was finished in September 11, fairly appropriate timing. A little picture of where we'd all like to be, particularly with COVID. We can't be in Melbourne, we can't be at the beach, but it's a nice place to dream to be. So just take a moment and pretend you're there. As we know, most of our clients aren't from this area. They've travelled many, many miles. Just a little bit of mental imagery to get back to where most of us are coming from. Travelling for miles, land of uncertainty and hope. As we all know, most of our clients are from refugee background, have poor access to healthcare and understanding of our Western health systems. In addition to mistrust, lack of Western healthcare systems, language barriers, puts our refugee community at a higher risk to poor long-term health outcomes. And I've been working in refugee health for over 10 years, and it's something I'm quite passionate about. Over these 10 years, to give you a little bit of a rough idea, our numbers have increased quite markedly into Toowoomba. You can see there from the stats during this project, they've nearly doubled. And due to this, we felt quite strongly here in Toowoomba about providing a better service at the back end. The front end we had pretty well sorted, but more the back end after arrivals. For those of you who aren't Queenslanders, it's a bit of a snapshot of our 5 settlement areas. Brisbane and Logan geographically have got a much larger population, but Toowoomba has seen a huge increase, and actually more than Brisbane and Logan. And that's, I guess, a big plus for us. We're doing it well, so more refugees want to come, and we're a rural area, so that's a big credit to us. But we also have a bigger demand in our services. We don't have a train system here, Brisbane and Logan do, so we had a lot of different issues to consider. So out of this, we were lucky enough to put in for a Nurse Navigator funding through the Innovation Fund. For those of you who don't know, EB10 is Enterprise Bargaining 10, and that was with Queensland Government, the Queensland Nurses Union, and we had a 12-month funding project for the Nurse Navigator role. The initiative was to enable a liaison between the acute setting and the primary healthcare setting. And we looked at collaboration partnership, cultural responsiveness, consumer and community voice, continuous improvement and clinical excellence. So that was our aim. But there was a few twists and turns. It was only 12 months, but by the time everyone got into the position, we had more 10 months. As we know, collecting data to identify refugees in our health system is non-existent. We can identify Aboriginal and Torres Strait Islanders very easily, but we can't. We can identify country of origin, language spoken, but not actually refugees. We have a very large university here, so we have a lot of migrants as well. Our original scope was too large. Resources, there was only one of me. Bureaucracy, we're all very much aware of there's a lot of that. And yes, I was a novice, but I'm certainly not now. So out of that, born our refugee Nurse Navigator role. And with Nurse Navigating, there is very much a tight criteria around that. But we aimed at our goal to look at equity and access, that enablers and issues along that to improve our health outcomes. So we redefined our scope. So our aims to improve the knowledge and cultural responsiveness to the staff working with refugees, to increase our health literacy of our community, and we looked at doing unnecessary presentations, failure to attend, and appointment gaps. We could do that because fortunately I had collected a database since 2010 of all the refugees that had come through our public health unit, public medicine unit, so we could do a retrospective data collection. Like all good projects, you have to be able to evaluate it, and that was our issue. So that's how we ended up doing that for our sample group, is looking at chart reviews and a staff questionnaire based around an education session. I was really trying to look at staff attitude, and it's very, very hard to do that through ethics and everything else. So we looked at doing an education of pre and post. So that was the best way we could collect that information. This is a bit of a snapshot of out of the 451 refugee chart audits that we did. Over that 12 months, we followed these people for 12 months. As you can see in our ED presentations, there were 376 with over 3,171 outpatients appointments and 142 admissions. And you can see the difference between the refugees and the rest of the population. That's just a snapshot of some of the data we collected. It was quite interesting. The most interesting part was the education session delivered, and that was a PowerPoint presentation I did, but it was more about getting clinicians' feedback and questions, and you can see the big difference. And it was trying to assess people's attitudes, which is very, very difficult. So that was a marked improvement. And a lot of the testimonials I got back about that is if you give the staff the resources and the information, it really changes their attitude on how they care for clients from a refugee background. So that was a really powerful piece of work we did. Out of the project came some pretty strong recommendations. One was about competency. When you talk about cold community, what we found is most policies and procedures are really talking about Aboriginal and Torres Strait Islanders is great, but it doesn't include non-English speaking people backgrounds. So that was something that was really interesting. To complement our existing model of care at the front end, we recommend that the inclusion of the liaison coordination, nurse navigator, whatever you'd like to call it, to be that linkage was to be incorporated into that model. A review of our interpreting access and our agreements was something we really needed to look at, because we have a lot of Kurdish Kurmanji speakers here, which unfortunately is not a written dialect, so that in itself caused a big issue here. And to ensure compliance with policy and action plans, to look at an equity and access unit. Some other hospital and health services have that, and you need that executive sponsorship for that to work. So that was our recommendations out of the project. Some of our really unexpected positive outcomes, one was COVID. COVID did cause us some problems in delivering education sessions, stopping our outpatients and seeing refugees, but we did many workarounds. But it was also the setup of the Vulnerables Community Committee, and I became the pivot point for the community with any COVID education, talking about isolation, and we ended up getting audio tapes done for us locally here. So it became our best friend, because then I became well known within the community as well as with the hospital as a key component in that role. So that ended up being a really good positive out of that, and we really realised the need and vulnerability of our refugees. So that was really a blessing in disguise. The journey, many ups and downs. It was an adventure. I like to look at them as road blocks, not closures and workarounds. I engaged with many really intelligent and talented people on the journey outside my normal scope. And health outcomes can be improved through change, education, and support of staff and clients. Consultation and collaboration is invaluable. The siloed mentality it's got to be removed. Unfortunately, everyone is bidding for the same funding bucket, so that causes issues. But through that vulnerable community connections, that really was powerful for us to be able to share information. Certainly professional growth was a highlight for me. My proudest achievement was certainly to watch the positive change of staff engagement and caring for refugees when you give them the knowledge and support to do so. So that was a really powerful, and it was a proud moment. Where to from here? Good question. COVID changed the world for all of us. Certainly the funding for the EB10 project was limited. That was at the beginning of the project, but unfortunately that wasn't continued here at our HHS. But out of it, through the support of the executive, I'm currently working as a clinical nurse consultant for the vulnerable communities, which is very much along what I was doing, but it's a broader collaboration of clients, including all vulnerables, not just our refugees. It's a great opportunity. And I'll hear from you for questions after. Thank you for letting me speak. Now I've got to stop sharing.
Thank you so much, Heather. That was fascinating, and well done for getting so much done in a very short period of time. And I think you're quite correct when you have those time-limited projects. Often a lot of the time is taken up just actually trying to get things organised, and before you know it, there goes 2 months. One of the questions that's come through, Heather, is what conclusions can you make, or did you make, based on the emergency department presentation numbers for refugees, and how did that rate of presentation compare to the rest of the population, do you think?
When you look at the statistics, they look quite high, but when you look at the numbers, it's quite comparative. So a lot of the presentations that actually presented with real emergency problems like anyone else. The numbers look skewed because they take longer. So the biggest issue was the time in the department for the refugees. I'm talking anyone non-English speaking, but we're looking at refugees here. Sure. The time seen was longer, and that was usually access to interpreters, it's the too hard basket, let's leave it. So the time difference was the biggest issue. Yeah.
Yes, indeed.
And newly arrived refugees, they tend to arrive at the emergency department because they don't know where else to go.
Yes.
So it's about education.
Yeah, and I think the point you made very early on in your presentation around the difficulty of data collection is a point so very well made. We're just concluding a really big data linkage program research project in Sydney, and again, because the minimum data sets on admission to hospital or to emergency doesn't collect visa status.
It doesn't.
We had to, the only way we could identify our patients were to do a fairly sophisticated higher level data linkage through Medicare and one of the Australian government data sets, and that's the only way to do it. And as you say, we can identify Aboriginal and Torres Strait Islanders, but we're still a long way away from that. And I don't know what the answer is to that. I'm sure there's a lot of vested groups all wanting their data to be recognised.
There's a lot of work being done in Queensland trying to change some of those data sets, but it's a long way off.
Yes. And look, another question's just coming through too about your GPs in the community. Do they, on the whole, do they bulk bill? Or is that one of the reasons for presenting to ED, do you think?
Yeah, look, there's a lot of work being done with the PHN and Multicultural Australia, which is a settlement agency, doing work with certain GP clinics to try and bulk bill them. And that's one of our big issues. And we have we've got 200,000 people in Toowoomba, but we've only got so many GPs that'll bulk bill, and we're all in one. Whereas Brisbane, you can spread out. We can't do that here.
Yes,
it's a challenge. It is a challenge.
Yeah, and look, I think the risk also is that if you do have a small select number of GPs who do bulk bill, you actually don't want to overload them.
That's exactly
with
right.
the entire refugee cohort, because we understand the complexities and the difficulties of sometimes working with these groups, particularly in the time it takes to see people and the all-encompassing mistress of Medicare, and 15 minutes for this and 20 minutes for that and blah blah blah. So it makes it really difficult for GPs trying to deliver quality service.
We're very lucky in Toowoomba that there's a collaborative approach between GPs and the hospital and community services. So everyone works really, really hard to work as a community to try and help the refugee community, which is great.
And just another question for me. Sorry, there's another one here. Hi, it's the refugee liaison midwife here from West Moreton in Queensland. We are moving towards ascertaining refugee background at a statewide level at maternity bookings in. It's a great step towards finding out service user numbers. So thanks for that feedback there, Jack. And I was going to ask, so with that, the education that you've done with your staff and being able to highlight all that, and well done. I mean, that's just fantastic evaluation that you've got there. They can be a very hard audience to crack, as we know.
It was a tough audience. We got a lot of thanks, we're not interested, but we got a lot of so it was tough, and it's continuing.
And was that done like as in sort of ad hoc in services at ward level, or was it more formal presentation?
It was more ad hoc. I tried really hard. If there was someone remotely interested, I would jump on the bandwagon, and sometimes I could get 20, sometimes I'd get 2. I'd get the pharmacy department. It was normally if they'd had an incident with a refugee as an inpatient, that's when I'd seize an opportunity, and that was a better way to go. So the emergency department, outpatients. I've been in this hospital for a little while, so it was also having a back door to some of the places, which helped.
Indeed, yes, and I think that that certainly is, sometimes it's not what you know, who you know, as they say, and being a well-known and respected clinician, that carries a whole lot of gravitas. So well done for using that as well. That's terrific.
Thanks, Sandy.
Yeah, I'll just put a call out then to the audience. Are there any other questions for Heather? You can still keep typing. Heather will stay online with us, so we can come back to that a little later, but if there's, I'll give you 10 seconds, people, to type. 9, 8, 7, 6, 5. Okay, all right, so look, thank you once again and good luck. Hopefully as we move forward, the powers will be to start seeing the contribution of programs such as those, and what a difference it can actually make to vulnerable communities. So hang in there and fight the good fight.
Thanks, Sandy. Thank you, everyone.
All right. Okay, so let's, moving right along on our program, let's now introduce our next 2 speakers, which Nihad and Becca from Victoria. So Becca, if you'd like to, are you starting off, Beck?
I'm starting. Is Nihad starting?
Nihad starting. Okay. All right, over to you, Nihad, and if you'd like to share your screen. Nihad, you were there a minute ago. Okay. All right. Now, I just can't seem to see Nihad there. Having some technical difficulties here.
Can you hear me?
Nihad, I can't see you there on the screen.
I'm going to start sharing the screen.
Okay. All right. That
And,
would be good.
And let me just.
Oh, okay. Nihad's now saying. Here we go.
Can you hear me?
We can't hear you very well, actually.
The screen's up. I'm not sure why they can't hear.
I can see your screen nicely, but you might just need to turn your microphone.
How about now? Is that better?
That's a little bit better. Yeah.
Give me 1 second. I might just clip this in. It might help. That might be better now.
Okie doke. Let's.
Beautiful.
Okay. Thanks, Nihad.
Thank you. So I'd also like to begin by respectfully acknowledging traditional owners of the land on which we meet and pay my respect to the elders past, present and emerging. I would also like to take this opportunity to thank you all for your time. My name's Nihad and I'm one of the Refugee Health Nurse Liaisons at Monash Refugee Health and Wellbeing. I also have with me today my colleague Becca, who also works in the role and who you'll meet later on in the presentation today. Today, we are both virtually here to talk about the Refugee Health Nurse Liaison role at Monash Health, which you'll hear us refer to as RHNL throughout the presentation. But before we get into that, a little bit of background. Monash Health as an organisation more broadly is Victoria's largest public health service, and we are very, very proud to provide healthcare to 1/4 of Melbourne's population across the entire lifespan. So that's from newborns and children, adolescents, adults, the elderly, their families and carers. More than 17,000 staff work at over 40 care locations across southeastern Melbourne, including 8 major hospitals and 6 community sites, some of which are Monash Medical Centre Clayton, Monash Children's Hospital, Moorabbin Hospital, Dandenong Hospital, Casey Hospital, Kingston Centre, Cranbourne Centre, and an extensive number of networks, extensive network of rehabilitation, aged care, community health, and mental health facilities throughout. The Monash Refugee Health and Wellbeing Service, more specifically, was established in 2011 in response to a large number of refugees within the region. And the service itself comprises of 4 main components or pillars. We have community development, as you can see on the screen, and this includes bicultural workers and community development workers who work not only with patients, but also with community organisations to support asylum seekers experiencing social disconnection. And a great example of this is we run a group called Thriving Women's that normally runs weekly pre-COVID days on a Friday, where women come together from diverse backgrounds to connect, to learn, and to participate in various activities. Another great example of community development is that our community development coordinator developed a service directory for organisations and professionals to use to connect those from refugee and asylum seeker backgrounds to appropriate community supports in the region. And this service directory is something that is reviewed annually and updated as well. Another component of our service is special services. And prior to special services, actually, we have primary care services. And this primary care service model looks at patients from refugee and asylum seeker backgrounds, particularly those who are newly arrived, complex, and those without Medicare as well. And in that team, it comprises of GPs, refugee health nurses, and counsellors as well, sit within the same team. Another component being specialist services. We provide specialist services, and we are very, very fortunate to be part of Monash Health and have access to infectious diseases physicians, paediatricians, and psychiatrists that also work within our team. The final component of our service is capacity building, and this is something that is done in numerous ways. Just as an example, we have a refugee health fellow who is one of our GPs, Dr. Mark Timlin, and he works with GPs in the community to build their capacity and is also available for things like secondary consultations. Another example of our capacity building is we also have a nurse on triage role, and this nurse sits within clinic Monday to Friday, and the phone calls essentially received as part of this role tend to also be often statewide. Another great example is we have the refugee health nurse liaison role, and that's something that Becca will talk a bit more about later on in the presentation. So the service itself is very much built on a multidisciplinary approach, and you might even refer to it as a one-stop shop. I guess the reason why we refer to it as this is because patients attending refugee health and wellbeing have access to a number of Monash Health services that are co-located and integrated into this one building. And this enables us and other teams to transition patients easily between the services as well. Being part of Monash Health has been a major strength for the refugee health program, as we're able to draw upon on the resources of a bigger hospital network, essentially, such as pathology services that are within Monash Health as well. In terms of setting, Monash Refugee Health and Wellbeing is located within the southeast region of Melbourne and covers Greater Dandenong, Casey and Cardinia localities. And this is great because the southeast region of Melbourne is one of the most diverse regions within Victoria, with its huge refugee and asylum seeker population. And I guess in terms of profile, I'll just let the dot points come up onto the screen. In terms of the profile of the communities that we work with, we know that communities of refugee background in southeast Melbourne have features that are not unique to our region, but are also reflected in a number of communities across Australia. And these dot points on the screen are potentially some of those things, but are not necessarily also limited to these things, such as low participation with primary healthcare, having a complex migration history, difficulty navigating the Australian healthcare system, and this is potentially even more difficult if one isn't able to speak English, varying entitlements to healthcare access, and this reliance on ambulance services and emergency departments. I guess this is the background and a great segue into discussing the refugee health nurse liaison role more specifically now, and the importance that this role holds. So I now introduce to you my fellow colleague, refugee health nurse liaison, Becca, who will continue the presentation on from here.
Thanks, Nihat. Sorry, 1 second. I've just lost, sorry everyone, I've just lost something. Okay, so I'm going to talk to you a bit about the refugee health nurse liaison role and how it came into being. So the planning and concept of the role was adapted from the Aboriginal liaison model. The pilot required ethics approval and a mixed methods descriptive approach was used for the evaluation. This was largely due to the evolutionary nature of the initiative. The RHNL role was piloted in 2013 to 14 at Dandenong Hospital, which is based in a high settlement region of Victoria. The role aimed to build capacity within the acute health sector to more effectively respond to the needs of asylum seekers and refugees. There are a number of data sources that we rely upon to continue, evaluate and improve the role, and the data sources we use today are the same as we used in the pilot, just with some tweaks and improvements along the way. For example, we've now incorporated professional feedback into the data we capture. We also attend a regular meeting within the ED department, which looks at patients who attend ED frequently. This has helped us to capture further data about patients who frequently attend ED. We've then been able to work together with them to come up with supportive care plans to minimise their ED presentations and engage them with primary care. An example of this is a patient of ours who would frequently attend ED for matters that could be managed by primary care, and we linked him with our GP services, and the positive outcome is that he now attends here regularly or is required for primary care rather than attending ED. In terms of record keeping, we routinely collect patient demographics, types of intervention, service provided, and the referrals initiated. This data is then analysed using basic statistical analysis. Patient feedback is routinely collected as part of quality assurance and is conducted with the aid of bicultural workers or clinical staff working with interpreters. We also rely upon narrative case studies, and this involves reflecting upon patient encounters and individual case studies. During the pilot, a thematic analysis of the reflective practice was done to consolidate learnings, and the learnings are reflected in the description of the role currently in practice. So in terms of where we are today with the role is hospital-based and provides a key link between the acute and community setting for patients from refugee and asylum seeker background. A huge part of the role is being a resource for healthcare staff and other services to access for secondary consultation. This can include anything from clarifying healthcare entitlements to support with more complex presentations. With particularly complex referrals, we often carry out joint assessments with hospital staff such as social workers or doctors, where we use an abridged version of the refugee health assessment and make recommendations that may otherwise not happen. So, for example, recommending that refugee health bloods are done whilst they are an inpatient if they haven't been done, linking to appropriate settlement and healthcare supports. Supporting staff and patients in this way ensures that patients are not lost to follow up upon discharge. There is also a strong focus on capacity building, which involves providing education to healthcare staff, patients, external service providers, including education settings for future workforce, and within the refugee health space. Some of the key learnings we've learned over time is that most referrals that come to us require some kind of intervention or additional service which may not have otherwise happened, and this is the unique value of the RHNL role. For example, we receive referrals from hospital staff who are unsure about entitlements for asylum seekers and refugees, or how to link patients who have no Medicare to primary care. We also have had referrals of patients without any identification or who have got expired visas and who have no supports and need to be linked in with healthcare and other supports. Another key learning is that the RHNL role helps to optimise quality of care and patient experience. It does this by providing a specialist refugee health lens within the acute sector. So, for example, by advocating for the consistent use of interpreters and culturally competent care. We've had a recent example during the pandemic where we had a COVID positive family from refugee background in the hospital setting. The members had to be placed in different hospitals due to the need for negative pressure rooms, and we did a lot of liaison with social work and the medical teams to advocate for things such as virtual visiting to keep the family connected, as well as working with the nurse unit manager and social work to advocate for the consistent use of interpreters rather than family members or staff who speak the same language. In terms of key outputs, and by key outputs I mean bang for buck, this is where we are. So we have defined care pathways which we follow. So for example, all inpatients who are discharged with a clear destination. This can either be linking them with refugee health for specialist and or primary care, or linking them with a community GP or settlement supports. Another key output is capacity building. Through capacity building, we have built relationships with services. This has meant, for example, that during the pandemic, although our presence in the hospital has been less visible, we've continued to receive referrals, which shows that these relationships are well established. Another key output is the Asylum Seeker Identification Directory. This has been a financial resource that has been developed to support correct patient registration and billing. It has enabled Monash Health to manage patients, such as asylum seekers without Medicare, to be billed appropriately using the state-funded initiative. This avoids a huge amount of financial stress for already vulnerable patients who might otherwise mistakenly receive an invoice. So that's the end of our presentation. Thank you so much for listening. I know there might be questions. If any questions occur after the presentation or after the webinar's finished, then this is our email address which you can contact us on.
Thank you so very much, Nihad and Becca. That was a really interesting insight into what's going on down in Victoria, and look, well done for continuing that service provision during COVID. I imagine that's been incredibly difficult, you know, for everybody involved. And you know, some of those initiatives that you're talking about trying to keep people connected across different hospital sites, you know, particularly when we know that there's been, you know, so many people are quite scared, and you know, a lot of misinformation in amongst some of the communities that we look after as well, to, you know, to make life even more challenging for people. I've just got a question around the asylum seeker directory that you've just made reference to. That's a great initiative, I have to say. Is that like a written directive that you've been able to give to finance departments and outpatients? Is that the format, or?
Yeah, it was. Yeah, it's something that actually a lot of the ward clerks use, and anyone like in ED kind of admitting the patient, so they have a kind of guide to know, you know, what evidence is needed to show that this person is an asylum seeker, and if they're an asylum seeker who has no Medicare, then they can be billed differently rather than billed as an overseas visitor.
Yes,
which is when an invoice would kind of
get
made.
Yes, and look, and my understanding is that, you know, each state has different provisions for that. In regards to, you know, what financial aid may be available. And I'll just give you an example. In New South Wales, we had a fairly straightforward 8 or 9 page policy directive, as it was called, that you know, talked about asylum seekers and who was eligible and blah blah blah. And then someone from the Ministry of New South Wales Health was obviously a little bit bored one day, so they took it upon themselves to rewrite it, and it came back out as I think it's 79 pages or 90 pages. So by the time you wade through this massive document, you know, to the 3 little paragraphs that you need, and it's been nothing but confusion, I have to say, with that. So, you know, it's actually gone back into the department, and we've asked for a rewrite, because a lot of my nurses' time, my asylum seeker nurses' time, is spent arguing with finance. Look, and I think that personal approach we've done in services with front of you know, house staff, as we call them, so clerical staff in admin positions, sitting in ED, in outpatients, where people are likely to walk through the door, and they found, you know, that information fantastic, because they're confused. They don't know what the government policy is, and they don't want to be, you know, making life really difficult and challenging for people who maybe are presenting unwell, who, you know, need to come in for appointments, only be told, oh, by the way, this will now cost you $130 because you don't have Medicare, and blah blah blah. So they're, you know, I think that's a terrific initiative, and you know, it would be wonderful if you'd be able to share that with your nursing RNA colleagues. I don't know if that's something where you could put as a resource onto our website for people to be able to look at.
I can certainly ask. Maybe Chiedza is best to answer that, but I'm
okay.
happy for
Chiedza
I
don't want to put you on the spot.
No.
Don't want to put you on the spot, but, you know, that would be you know, and now, and particularly for those states and regions that actually haven't developed a resource like that, having an example of how you've put that together, and then where people can then apply their local conditions, you know, can be a real bonus, because, you know, as I say, you need almost an accountancy degree to work all this stuff out, and things change all the time. Look, I think the other thing to say, congratulations, is that you've got a really well planned program and a really well planned framework that surrounds your your programs as well. And if everybody knows and understands that framework, they've got a common purpose, then I think that makes life a whole lot easier as well. Now, we do have a few questions coming through. I'm just going to go to the Q&A screen. Oh, yes, so someone's agreeing, saying yes, they would like to have the resource that we're talking about. Oh, and someone just saying congratulations, that was great that they needed to leave to attend to another meeting. We just had a bit of a chat before about COVID and how we're doing clinical appointments. So you're back mainly doing face-to-face appointments at the moment?
So we're doing a mixture. We're starting to opening up more face-to-face now, but we're still doing a lot of telephone as well. So it's a mixture, but we're doing a little bit more face-to-face than we were, say, a month ago.
Yes, yeah. As things are starting to relax a little bit, yeah. And I think I was commenting that there's some things that you can easily do face to face, but there are other clinical things that you just have to be able to see the person in front of you. I have to say, as an aside, our dietitian that we have here, she's gone mainly to telephone and appointments and telephone at home. And what's been really good for her is that she's been able to see what's been in people's fridges. So she can say, oh, show me what's in your fridge today. So, rather than sitting them in a, in a community health room or in a clinical consultation room where they can talk about maybe the stuff that they've got at home. So she's seen there's been some real advantages to that. It's funny, isn't it? Now, Chitsa, you're the boss of these two wonderful nurses. Is there anything else you'd like to contribute here to the discussion?
I wouldn't say I'm the boss. I think we work together really well. They probably are the boss of me.
Apologise. Sorry.
I think the only other learning that we got from the COVID, supporting and managing COVID-19 patients across the hospital network has been the real importance of people getting their refugee health bloods on arrival. Because we've had people who've had COVID complications related to latent TB. So I guess it's really important that in the different states that you're in, that if medical information is being provided for any patients that have latent TB or any other respiratory-based issues that could have been picked up in the refugee health assessment, that it does help inform the treating team if they do end up in hospital. So I guess that's been our biggest wisdom from the pandemic, is that the work that refugee health nurses do and ensuring that the refugee health bloods are done is very essential.
Yeah, that's a really good clinical point. Someone needs to write that up, at the end of this, as a clinical paper, looking at the outcomes for those people with latent TB, because that's a really important learning for everybody, of course. And as you say, particularly then the importance of having that on arrival health assessment, when we're confronting these sort of things as well. Leanne is just chiming in with the chat saying that home visits are also good to see if clients have opened their mail, and explains if they did not attend to their appointments, if indeed they haven't actually opened the mail that's given them that letter of appointment in the first place. And I think that's a point very well made. Indeed, yeah. Okay. Now I'll just see if there are any other questions coming through. Not at the moment. All right. So look, I'd just like to say thank you once again. They're both our excellent presentations. I learned a lot today, and well done to the team in Victoria. You're in our thoughts. I have to say, as a New South Wales person, I'm on that on the internet every morning keeping the countdown to see what are the numbers in Victoria, because I know that that's so important. So well done, you're under 10 again today, you're down to single digits, but some concerns there about the spread into rural and regional, and saying that New South Wales is certainly not out of the woods. We've had a couple of little local outbreaks this week. which has emanated from a couple of GP practices. So that's of concern, of course. So maybe this will be the new normal. We would like to think that we will meet together face to face at the Refugee Nurses Forum in a year or two, but we'll just have to wait and see, inshallah, as they say, God willing, huh? So, all right, once again, thank you very much. This recording will be online on our RNA website for people to be able to catch up on. If you do have any other questions out there amongst the audience and you haven't been able to answer that, please just email me those questions or email to the RNA mailbox, and we'll see if we can get you some answers. So thanks very much. Well done, team, and good afternoon. Bye-bye.
Thanks, Sandy. Thanks all.
Bye-bye. Bye-bye.